शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
I welcome you all for this webinar. Durgadas sir, can we have you here for a few words for the initiation or inauguration of the program?
Good evening, everybody. First of all, I congratulate Dr. Shilpa for this program. This is the first program after our state conference. I thank Dr. Paresh Patel sir for coming to for today's program to address us on individualized protocol and monitoring of IUI cycles, and also Dr. Sachin Dalal, who is going to address on how to improve the IUI success rate. Just now I was talking to Paresh Patel sir that these are the things which we require as a routine practicing gynecologists. We are not IVF specialists like Vanitha Medgood madam and all. We have our own obstetric practice, gynecological practice. Along with that, we practice infertility, and we need this type of advices and guidance. For that, I really congratulate Shilpa for choosing such a beautiful topic. With all my respects to Vanitha Medgood madam, whom I have lots of respect, I also congratulate moderator Dr. Vidya Vannavat. With these few words, without wasting much time, please proceed, Dr. Shilpa. All the best for today's program.
Thank you, sir. I will take this opportunity to introduce all the chairpersons and the speakers for this program today. We have wonderful speakers today, Dr. Sachin Dalal and Dr. Paresh Patil, who are very innovative and eminent in this field, who are sharing their knowledge today. Arun, can I have CV of Paresh Patel, sir? So Paresh sir is the gynecologist and fertility expert, Kushi Fertility Center, DISA. He's done more than 6,000 IUI cycles with in-house IUI laboratory, doing regular training batches for basic infertility training. Past president, Palanpur and OG Society, member, FOXY, IFS, ISAR, SFM accredited sonographer, FMF ID. So, Arun, can I have CV of Dr. Sachin Dalal, sir? So Dr. Sachin Dalal doesn't require any introduction. He's a famous obstetrician, gynecologist, lab surgeon, and IVF specialist from Bombay. His affiliations, Madhu Hospital, Bandup, Embryon IVF, Vikhroli, Fortis Hospital, Mulund, Jupiter Hospital, Thane, Surya Hospital, Chembur, won various awards at MOX conferences, and he runs one WhatsApp verdict group where he shares his knowledge to all the interested practitioners. This is Dr. Vanitha Medgood ma'am. She is the chairperson for the program today. She is Medical Director, Care Center at Belgaum. She is pioneer in infertility in ART with more than 25 years of experience in ART, specialized training in ART, Australia, Singapore, credited for first test tube baby of North Karnataka, founder president Belgavi Menopause Society, chair fertility and aging committee IMS, patron member of PCOS Society, EC member Karnataka chapter, member of INSARC, president of OG Society Belgaum, state award IMA BC Roy Award, ISAR Dronacharya Award 2024, Eastern Award, the Iconic Women of the Year 2020 Bangalore, Dr. Maheshwari Award, AICOG Kochi 2007, awarded in Kittur Utsav by Government of Karnataka 2024. Ma'am, I welcome Dr. Shobha Gudi, ma'am, for her few words for this program today.
Yeah. Will I be interrupting? You want me to speak later? Or shall I just welcome on behalf
Yeah,
of
ma'am, you can
KSOGA?
welcome.
Yeah,
Just
congratulations, Shilpa, for your consistency. I feel you have been a very consistent
thank you, ma'am.
chairperson, and that is what is required for KSOGA today. That the committee chairs bring in constantly some new thought and some new programs into the field, and most importantly, I think you are recruiting very great faculty for us. So
Thank you,
thank
ma'am.
you very much for bringing in Dr. Patel and Dr. Dalal, very, very seasoned practitioners in the field, and a lot of learning to happen for Kasogians. So all the very best. And of course, my friend Vanita is there. Vanita, welcome to this to Kasoga platform. Of course, you are one of our seniors, so this is your home ground too. So thank you very much, Shilpa, for having me here, and all the best for solid learning during these 2 hours. All the very best. All the very best.
Thank you, ma'am. Thank you, ma'am. Arun, can I have Dr. Vidya CV?
No, I have not given because not to waste time in this. We'll start the talk.
Okay,
I
please
am
take
Dr.
over,
Vidya
Dr.
Verma.
Vidya.
I
Yeah,
am
let's
from
start the
Hubli,
program. Yes.
and I am a IVF consultant. That's enough.
Yes.
And
Please start
Shilpa
the
is
program.
our chairperson, Infertility Committee of KSOGA, practicing in Bangalore.
Let's start. Yes. Can we have Dr. Paresh Patel screen so that sir can start?
Yes. Just a minute. Sorry. Is it visible on the screen?
Yes, sir.
Hello. Yes. Thank you, Mr. President KSOGA. Thank you, all the team members of Infertility Committee KSOGA. Thank you, chairpersons, and thank you, Dr. Vidya, for this opportunity. Over the next 30 or 40 minutes, I will be sharing my real-world experiences in non-IVF or IUI stimulation cycles. What are the different protocols and how I monitor them? So this is my small disclaimer. It is basically my experiences. So there are things where my views are little different from what textbook says. So if anybody is not happy with my thoughts, it's okay to me. No problem with that. But these are my all real world experiences. So basically, when we do any IUI or non-IVF cycles, the success rate depends mainly on two factors. One is how I select my patients. IUI is not for every patient. There are specific indications. Then how I stimulate those selected patients. Basically, my topic is stimulation and monitoring. So I'm not touching the other parts, but then IUI should be done only when it is indicated. It will not be effective to each and every patient. So we need to understand it very clearly. It is not for everyone. It is for those who have problem with the functional working. If problem is anatomical, IVF is not going, IUI is not going to work. The answer is an IVF. But when the problem is functional, like anovulation, low ovarian reserve, unexplained cervical factor, or mild endometriosis, in those cases, IUI really has a very high success rate. So we should give proper trial to every couple before moving on to the definitive IVF treatment. So when I actually start stimulation for my any patient, I decide goal at the beginning of the cycle. So I will be discussing what are my goals in particular patient, and then which are the challenges I come across while I do stimulation of those patients. So when I start a stimulation of a female who is already ovulating, making just one ovum doesn't make any sense. If we can make 2, 3, or 4 good follicles, then that patient definitely has a higher success rate. Now, patient with regular cycles, why she should not conceive? So there can be other reasons like mild male factor, minimal endometriosis, cervical factor, ovulatory PCO, and unexplained. In these all categories, female is already ovulating and still she is not conceiving. Here, if we can make 2, 3 or 4 follicle maximum, then success rate is always higher. We have done one trial at our center in 2020. That time I have monitored my 110 continuous cycles of IUI or non-IVF cycles. In those cycles, the maximum success rate was there, the patient who has 2 follicles. Thereafter came patient with 3 follicles. Thereafter came patient with 4 follicles, and single follicle, most of them were an ovulatory PCO or low AMH group. So when patient is not ovulating, doing just ovulation is enough. So my criteria is, like, if I have 1 follicle in a normally ovulating female, I would not put that weight in my that cycle. That cycle is not a good cycle for me. If I can produce 2 or 3 follicles, then that patient will give good results in that cycle. So to complete my these goals, monofollicular as well as multifollicular, I take into consideration how that patient is, whether she is normal responder, hyper responder, or poor responder, and then I decide what to do in that cycle. Coming out of the challenges, we face this many challenges while we start the stimulation. There can be problem with the follicular recruitment. In spite of giving everything, follicle doesn't develop. This can happen in severe and ovulatory PCO group of patients. We may see consistently large follicle on day 2 or 3 of the cycle in certain patients. These are the patients with extreme low AMH, where basal FSH is little high, which comes very early in the early luteal phase of previous cycle. And because of that, when we actually see this patient, they have 12, 13, 14 mm follicle on day 2 itself. So it's not a good condition. When we are planning a multifollicular development, at that time, if follicle number crosses beyond 3, 4, there is a real chance of premature research. Because I don't have good experience of using antagonist in my practice, I need to do something for this patient so that follicle number doesn't cross 4 and pregnancy rate remains the acceptable. Now we have very big basket, including oral molecules, injectables, recombinant urinary, which molecule to use in a particular group of patients. Many protocols are there. Letrozole followed by gonadotrophins, daily gonadotrophins, letrozole along with gonadotrophins, which protocol to be used in which categories of patient. That's also a big challenge. How to monitor that patient according to the protocols throughout the cycle. And many times we come across a thin endometrium during stimulation. When follicle is looking good, but endometrium is not that great, 5, 6 mm. And at that time, what to do during stimulation? So that I will touch upon when to trigger, with which molecule to trigger, and most importantly, how to predict and how to prevent OHSS during your non-IVF stimulation. So we will address one by one these challenges during this course of half an hour or so. So basically, recruitment can be a challenge in patient having an ovulatory PCO. These are the patient having cycles coming at 60, 90, 120 days interval. And when we directly start the stimulation, we don't see any follicle after letrozole or clomipene or injectables. And the reason is very high LH levels and very high androgen levels. So basically, this group of patients require some form of pre-treatment. So our goal are to reduce the insulin level, to reduce the androgen levels, and to reduce the LH level. We can very effectively do this by giving metformin as an insulin sensitizer. We can give progesterone in a late luteal phase of previous cycle. We can give cyproterone acetate containing OC pills. And we have many pregnancies at first IUI itself after 10, 12 years of midlife, when the patient's LH was 19, 20, which was brought down to below 5, and then I started the stimulation. So these group of patients, they definitely require some form of pre-treatment. When we see larger follicle on day 2 or 3, these are the patients having AMH less than 1.1. So AMH is basically a break to FSH. So when AMH is very low, FSH comes very early in the previous cycle's luteal phase. And because of that, when we see on day 2, the follicle is 12, 13, 14 mm. So that patient ovulates very early and pregnancy doesn't happen. We need to prevent this phenomena. How we can very effectively we can prevent? Just give estrogen in a late luteal phase of previous cycle from day 21 till she bleeds, or if cycle is short, just before 7-8 days of period, and then on day 2 when we see the ovaries are silent with 2, 3, 4 follicles on either side, and that's basically a normal patient having just low number of follicles. We don't want that much follicles in non-IVF cycles. We just require 1, 2, 3 good follicles. So don't be scared of low AMH. I have got pregnancies at every level. The lowest was 0.06, 0.1, 0.2, 0.3. If you can correct the physiology, Poseidon group 3 is a patient where you can expect good egg quality and you can have a pregnancy. You will be able to give their own genetic child to that couple. So never a egg donation in a patient with any AMH without trying enough. Many will conceive and you will be very happy. Premature LH surge is a challenge when I am planning a multifollicular development. So what I do basically, I add letrozole with HMG alternate day. So the advantage with letrozole is that it will reduce the estradiol levels. So in spite of 3 or 4 follicles growing, there are many pregnancies. So letrozole itself prevents premature LH surge. So basically what I do, I start letrozole from day 3 to day 7. I give 1 shot of HMG on day 4, 1 shot HMG on day 6, 1 shot of HMG on day 8, and directly examine on day 10. There, if my dose calculation is perfect, everything is almost ready. It's a beautiful protocol for normal responders as well as some poor responder class of patients. Very patient friendly, just 2 visits, very cost effective, and it has the highest success rate. We have many pregnancies with this protocol. So because I have tried antagonist in my few of the cycles, the pregnancy rate was not great in my experience. So in non-IVF cycle, I don't use antagonist. I use oral molecules along with gonadotropins, and this is how estradiol levels are in check in spite of having 3-4 follicles. So now, very importantly, which molecule to be used, whether we should use oral ovulagens or injectables or combination. Oral will not be effective when married life is too long, 10 years, 12 years, patient has taken treatment at many places. It is just a wastage of time. So use a good protocol there. But when married life is short, when couple is young, definitely oral medications needs to be tried first and then move on to the injectables or gonadotropins if she doesn't conceive with oral molecules. My preference is letrozole. I have used clomiphen only till letrozole was not available. But once it is there in the market, I have always relied onto the letrozole because of its physiological things. It doesn't affect the endometrium, mucus is good, pregnancy rate is good, and as people say, it is not causing always a monofollicular. It develops 2-3 follicles in many patients. So it is as good as gonadotropins. If used in a young couple with short active life, it has a really good success rate. Extended letrozole, I have not used that much in my practice. So I'm not a proper person to tell whether it is good or bad. So I will not touch upon that part. I will move to the injectables. The REC-FSH has very limited indications in non-IVF stimulations. It has definitely an edge in a patient having an ovulatory PCO class of patients. REC-FSH has a little learning curve. So you need to be used to use this properly, and it takes some time to get used to it. But if you can use this molecule in an ovulated PCO class of patients, it has produced wonders for me. Patients advise IVF, failed IVF, and then they conceive with just good ovulation induction. So REC-FSH only for the anovulated PCO group of patients, and as a sure shot, as a last cycle. When my everything fails, I come back to the REC-FSH. Daily gonadotropin, REC-FSH plus HMG. It has produced many pregnancies. In rest, all the categories like normal responder, poor responders, I relied on to some LH activity. For normal responder, simple urinary HMG is enough. No need to use HC-driven LH. They have enough LH and they can conceive very easily with just urinary gonadotropins. When it comes to poor responder class of patient, definitely HCG-driven LH activity has an edge. Low dose HCG protocol has produced some miracles in my practice when I have used in low AMH group of patients. So this is regarding which molecule to be used in which class of patients. REC-FSH in N-ovulated PCO, all other gonadotropins, HCG-driven LH activity in poor responder group of patients, low dose HCG in poor responders. Surprisingly, there are many PCOs who have given results with low dose HCG in my practice. And when my patient doesn't respond to REC-FSH, I use low dose HCG in those categories of patients also, and we have many pregnancies. There are many protocols. Which protocol to be used for which class of patients? So as I told, I need to decide whether my goal is monofollicular or whether my goal is multifollicular. So multifollicular goal will be there in all normal responders, in poor responders with regular cycles, where there is already one ovum is released every month, still she is not conceiving. So I will try to make 2, 3 or 4 follicles. So for normal responders, my choice of protocol is letrozole along with gonadotropins. Second good protocol is daily gonadotropin. It's a little costly protocol, but it has given many pregnancies when my patient is for just 1 or 2 cycles. And if she can afford, this is a wonderful protocol where you can rely getting pregnancy earlier. When it comes to poor responders, again letrozole with HMG and a little higher dose, letrozole followed by low dose HCG, daily gonadotropins followed by low dose HCG in last 2-3 days. It has produced dramatic results in my poor responder class of patients. When it comes to hyper responder, I choose to select a follicle with oral medication and then I support that follicle with either REC-FSH or HMG. So my first protocol is letrozole followed by REC-FSH. Second is letrozole followed by HP-HMG when there is an expected recruitment after the letrozole. Letrozole followed by low dose HCG in patients who are not responding to my REC-FSH. Stimulation and step-up protocol using low dose REC-FSH is a standard protocol for hyperresponder group of patients selecting a single follicle and getting many pregnancies. So these are basically which protocol to be used in which categories of patients. Most importantly, how to decide dose so that the follicle number remains in check. This is, I have done an analysis of my many cases in COVID time, and then I have come with my own calculator, which I am sharing with all of you. So for normal responder, when I am planning a letrozole along with alternate day HMG protocol, I take into consideration which type of patient it is, normal, hyper or poor responder, and what is the age, what is the BMI of that particular patient. And accordingly, I have found out that using these dosages, we have got 2 to 4 follicles in almost more than 80% of cases. There will be 20% of patients who will respond haphazardly. They may develop more follicles. So we will see what to do with those patients in that situation. But 80% of patients will respond as per your wish when you apply this calculator. So which is this? In normal responder, when age plus BMI is 45 or less, give letrozole only 2.5 milligram per day and HMG only 75, no more than 75. When this total goes near 50, letrozole 2.5 milligram OD or BID, HMG 2.5 or 150. When it is around 60 or near, letrozole 2.5 milligram always BID and HMG 150 or if required 187.5. My second cycle, when I am doing in these categories of patient, I don't then look at the calculator. Then response to my first cycle is my guide for dose calculation in the second cycle. With this thing in mind, we have seen patient responding perfectly in almost 80% of patients. When it comes to poor responder, when I am planning a letrozole along with alternate day HMG regime, same protocol, just 37.5 unit higher in each category of patient. And how I give, I start non-IVF simulation on day 3, 4, 5, 6, 7. One shot of HMG on day 4, whether I am giving 75, 112.5, 150 or 187.5. Second shot on day 6, third shot on day 8. In most of the patients, 3 injections are enough. Very few patients will require 1 or 2 extra doses and that to be decided after monitoring. So this is the calculator when I am planning letrozole along with alternate day HMG regime in my normal responder as well as poor responder class of patients. While I am using daily gotrophils, what dose should be used? So it is either 75 or 150 only. Don't use a dose beyond 150. Otherwise, it will become an IVF cycle. In spite of spending so much money, patient will not get anything. So when age plus BMI is up to 45 in normal responder, just 75 units. When it is 50 or more, just 150 units. This should recruit 2 to 4 good follicles in that particular patient where you don't require to use antagonist and pregnancy rate is good. But when with any dose, if follicle number crosses 4, pregnancy rate is definitely not good. We are putting our patient at risk of OHSS and multifetal pregnancy unnecessarily. So my dose should be such that it develop just 2 or 3 good follicles in any case. When it comes to poor responder, just 1 dose, 150 units daily from day 3 of the cycle. When it comes to hyper responders, it is a step-up protocol. Start with 37.5, give it for 5 days. If no response, increase by 12.5 units every 5 days. But to be honest, practically it is not possible to give these dosages. So many times I start with 50 units or 62.5 units in an obese class of patients. And most of the patients, they develop 2 or 3 good follicles with these doses. When I use 37.5, they develop just 1 follicle. Now, letrozole followed by REC-FSH. This protocol I have used a lot in my all PCOs. So, my choice is letrozole followed by REC-FSH when there is no proper recruitment even after reducing the androgen and LH levels. When there is a recruitment of follicle beyond 10, 11, 12 mm, I can choose between HMG or REC-FSH. Again, you can use REC-FSH, you can use HMG if follicle has come out which is more than 12 mm after 5 days of letrozole treatment. So how to decide dosages? When age plus BMI is 45 or less, never go beyond 50 units of REC-FSH, letrozole just once a daily. Basically what letrozole does, it accumulates androgen inside the follicle and in that fashion it increases the sensitivity of that particular follicle for the gonadotropins. So our dosage should be lower side. So just 37.5 or 50 units when she is thin and quite young. no more than 50 units of REC-FSH to be used in a young patient where age plus BMI is just 45 or less. When it is 50 or near, 49, 50, 51, 52, 53, dose of 62.5 is a wonderful dose where you will recruit 2 to 3 good follicles. So letrozole OD or BID and then REC-FSH 62.5 daily for 4 days, then monitoring and accordingly. When it is 60 or near, then 75 is the dose of REC-FSH. Letrozole is BID. In no condition, our dose of REC-FSH should cross 75. Otherwise, you will have to face hyper response in many cases. So highest dose of REC-FSH is just 75 units in non-IVF cycle. For HMG, it is 187.5, even 2 to 5 I have used in my practice. I have used 300 also, but that is not the advice. For poor responder, using 2 to 5 will not cause any problem. But if you don't read your patient properly, and if you will use such dosages, you will have to face many hyper responses in your practice. Whenever I am planning to use low dose HCG in my any of patient, whether she is poor responder or whether she is non-responding PCO, the dose is standard 150 or 200. No alteration according to age or BMI or anything. Just 150 or 200 daily sub-Q at the same time. Just 3, 4 or 5 doses and follicle will be beautiful follicle. In no condition, dose should exceed 200. Never start low dose HCG when follicle has not reached up to 12 mm. Otherwise, that follicle will go into atresia. So once it is 12 mm only, that follicle has almost 85% of LH receptors. By giving low dose HCG, you can expect a perfect follicular growth. It increases the androgen level, which provides a substrate for the estrogen production towards the end of the follicular phase. And endometrium will be beautiful here. Now I have decided protocol, I have decided dosages, I have decided my molecules. How will I monitor that cycle? So I do just TVS, no any blood investigations during my all non-IVF stimulations. How frequent TVS? So first scan on day 2 or 3 is must for any non-IVF stimulation. Without scanning, you cannot start any cycle. So what we actually see on that particular day, you have to count each and every follicle on that day. You have to see that there is a proper shedding of the endometrium. There is no big follicle. Preferably, there should not be an active corpus luteum at that time also. So when ovaries are silent, you can start stimulation in any patient very confidently. Hello. Okay, it is. I'm audible.
Yes, sir, you are audible, sir.
Okay. So how frequent TVS? So it depends on which protocol I am planning. When it's an letrozole along with alternate day HMG protocol, then just one scan on day 2 or 3, directly scan on day 10. So 3, 4, 5, 6, 7 letrozole, day 4, day 6, day 8 HMG, and day 10 TVS. In almost 80% of cases, everything will be ready to trigger on day 10. If required, you can ask her to come for sonography on the next day or 2 days after if follicular growth is lagging. When you are planning daily gonadotropin, then first scan on day 2, day 3, then after 5 days, second scan is must. Further scan depends on finding on that particular day. When I see on day 8 or day 7 after giving 5 days of gonadotropins. So 2 or 3 scan in daily gonadotropin protocol. When I am planning letrozole followed by REC-FSH, letrozole followed by HMG, letrozole followed by HCG. So day 2 scan is must. Then after the last tablet of letrozole, I will do one more scan. On that day, I will start the growth droppings and I will call her after 4 days if follicle is not bigger than 12 mm on that day. If follicle is 14, 15, then accordingly you can call her on that day. After 4 days, if follicle has not reached a maturity, again you have to ask to come after 2-3 days. So no more than 4 injections at a time. Otherwise, you will end up in a very hyper response, particularly when you are using REC FSH. So this is how you should do. See all follicles more than 10 mm at maturity scan or recruitment scan. And that will help you preventing OHSS, modifying your doses, deciding days of gold droppings. So all follicles which are more than 10 mm, you have to count every follicles. I'm not that much fond of a Doppler in my practice, but in a maturity scan, you can use Doppler and there should be 75% of vascularity around the mature follicles. I don't go for any estrogen level or progesterone level or any blood reports during IUS stimulation. So this is how I monitor my cycle. Just TVS, baseline scan, recruitment scan, maturity scan, and then optional scans. So 2, 3, or 4 scans are enough, and you can complete your cycle very effectively. Many times we come across a thin endometrium where follicle is good, 16-17 mm follicle, and endometrium is just 5 mm. Basically, what it suggests, if there is no problem with the endometrium itself, then endometrium should grow because of estrogen coming from that mature follicle. We are addressing many patients where LH is not effective, particularly when patient is 32, 33, 34, low AMH. In those cases, because of high basal FSH, follicle grows at 16-17 mm. Endometrium remains just 5-6 mm. Just give 2 or 3 injections of daily low dose HCG at that point of time. And endometrium will grow very nicely. Perhaps low dose HCG has something to do with implantation also. So there are many patients where I have seen endometrium not improving that much, but many of them have conceived after marriage for 10-12 years. So it has a role in development of follicle towards the endofollicular base, also in the implantation. I don't pull my follicle beyond 20 mm because my almost all cycles are gonadotrophin cycles. But when you are using only oral molecules, you can pull till 22 mm very effectively, no problem with that, with only letrozole cycles. 7 mm triple line endometrium is a good endometrium. No need to pull too much. If follicle is 20, endo is 7, just trigger and do good IUI. You can expect pregnancy. When to trigger, with which molecule to trigger. So my trigger criteria are very simple, just 2D criteria. So what I see, follicle size, my preference is 19 because I am using all my cycles, gonadotropin cycles. But again, when patient has low AMH or whenever you have used only recombinant, in that case, FSH activity is higher and LH receptor expression becomes earlier. So in a progesterone class 4, you can trigger at 17 also, no problem with that. In a recombinant cycle, you can trigger at 17 also. And we have seen pregnancy in a 14 or 16 mm follicle also while using recombinant. So with recombinant or in a progesterone group 4, trigger little earlier. All other groups, 19 is a good size to trigger. Endometrium, my preference is 9 mm. But then if it doesn't grow beyond 7 mm, it's a good size. Don't pull beyond that and try to see a little haziness on the distant border of the endometrium. This is because of progesteronic action, which comes just before ovulation after LH surge. So basically, we are supporting a natural LH surge. We are making sure the reinitiation of meiosis has started and egg will be mature. So learn to see a little haziness towards distant border of the endometrium. At that time, put a Doppler on a follicle. If the flow is good, just give the trigger. Also, learn to see the cervical mucus. Different stimulation protocol will show you a different kind of mucus. And when LH activity is good, the mucus will be very good. It can be a natural LH activity. It can be from HCG-driven LH activity or low-dose HCG protocol. So cervical mucus, endometrium, follicle, and perifollicular flow. This decides my trigger. With which molecule to trigger? I never use agonist trigger in my non-IVF cycles. It causes very early lipolysis and pregnancy rate is not great. I don't use dual trigger also. So I use only HCG at a proper time in my all non-IVF stimulations. I use 10,000, but it's okay to use 5,000 recombinant. All have equal efficacy. You can use IM sub-Q, whatever you want to use, all are equal. All are equal. Just only thing, when you fear OHSS, use a dose which is on a lower side. Don't use 10,000 or recombinant. How to prevent OHSS during it should never happen. It should never happen. For that, your protocol, your dose calculation, your age, BMI calculation, all should be perfect so that you will not have to face this situation. So there are certain protocols which I would tell dangerous protocols. Why? Because there is a higher chance of hyper-response. Which are these protocols? Whenever I have used REC-FSH in my any stimulation, see what REC-FSH does. FSH receptors are there at all sizes in follicle. So it will grow all the follicles. HMG will not grow all the follicles. So when you are using REC-FSH and you have done mistake in dose calculation, you may see many follicles developing after just 5 days of REC-FSH or after 4 days after letrozole. In that condition, you have to be cautious unless you give HCG to your patient. That patient will never go into complication. So predict and then prevent OHSS. Don't treat. We need not treat OHSS in our career. Predict it and then prevent it. How to? Which is the other protocol? My preference is letrozole with alternative HMG normal responder group of patients. But accidentally, I have not read ovulatory PCO properly. And I have applied that protocol in PCO group of patients. Suddenly, when she came on day 2, she has 6 mature follicles and 5 follicles which are 12-13 mm size. So this is a condition where we will not give HCG. Don't give HCG. What to do? We'll see. When to predict. So these are the two situations where you have to face hyper-response. Anytime using REC-FSH is a real possibility. When you have used letrozole with alternative HMG in PCO group of patients, it's a real possibility. When to predict? While on recruitment scan, you see more than 4 or 5 follicles which are growing beyond 10 mm. Keep your doses on lower side. Otherwise, all follicles will grow. That is not a good condition. While on a maturity scan, when you are trying to trigger that patient, along with 2, 3, 4 mature follicles, you are seeing 3, 4, 5 medium size 12-13 mm follicles. Don't trigger it. Don't trigger it. You may have to face hyper response. So this is how we can predict. And then what we can do in that situation? Just ask her to come after 3 days. Allow those follicles to be ruptured by natural LH surge only. You can avoid trigger altogether If you are fearing too much, ask them not to have intercourse. So that early OHS will not develop, late OHS will also not develop. If you are planning to give trigger, then limit your dose to 5,000. Add Caberlin just for 7, 8, 9 days to cover the HCG which trigger you can give. But still, these patients are at risk of OHSS if they become pregnant. Particularly if it's a twin or triplet pregnancy, then she is at a little high risk. If you are very much scared of 10, 10, 12, 12 follicles on either side, and you want to cancel that cycle, just give daily antagonist for 4 days, Caberlin, plenty of fluids, and nothing will happen. Don't be afraid. Just predict, don't give HCG, and everything will be taken care of. Okay? So thank you very much. Thank you everyone for patient hearing. I have shared my experience in a very short span of time. Whatever the queries you have, you can ask. You can send me personal messages, and I will definitely answer each and every query when time permits. I am very much thankful to all my trainee fellows who come regularly to our center, and because of them only, I get daily stimulation to read new things, to analyze my data, and thank you very much. Thank you again.
Thank you, Paresh sir. Shilpa?
I should stop sharing?
Yes, sir. Yes, sir.
Yes.
Shilpa, will you have questions now?
Sir, excellent talk, sir. Lots of practical points. Everybody, as a practicing gynecologist, we enjoyed a lot. Each and every bit, how to stimulate, each and every step of IUI. It was really a wonderful talk. Thank you, sir. Thank you.
Thank you very much, sir.
Yes, sir. It was very, very elaborate and very informative talk, sir.
Thank you. I have tried to put my experience in a small talk.
Yes, yes.
Yes, sir. Experience speaks.
Hope
Yes.
it's palatable.
It's not the bookish. It's the experience speaks.
Yes,
That's required for the practitioners.
This is what I practice in my practice. This is what I do in my practice.
Wonderful, wonderful.
So many people are
Sachin
asking
bhai,
how
you liked it?
Sir, Paresh sir.
Thank you very much, Sachin.
There are questions that how you make low dose HCG.
Yes.
This is the one question in the chat box.
Okay. So it's very important. So basically, I use, should I speak brand or just molecule? Because there is 2000 available in the market in the liquid formulation.
Yes.
And from that 2000, you can make HCG, low dose HCG, that is 200 or 150, very easily without doing any dilution. You need not add anything. Just bring that vial, 1 ml contains 2000 unit. From that, I'll just take 0.1 ml. Now, how can we draw 0.1 ml from this 1 ml? So for that purpose, I have devised an insulin syringe, the red one, which has 40 units. So each unit is a 50 unit, each mark is a. So if you can draw just up to 4 mark, it's 200. Up to 3 mark, it's 150. So draw between 3 and 4 so that you will not face overdoses. Also, take some air before pulling the drug so that you will be able to see that perfect mark where the column is.
Yes.
And there will be no overdoses. Yes.
Dr. Paresh, you have beautifully narrated all the points regarding the molecule dose and all the protocols and how to avoid complications. Out of your own experience, it was really an eye-opening experience and we enjoyed it. There are some few comments regarding the low AMH and your protocol was good, but if it is too low, that up to 0.06, and usually we just wait for other treatments like DHEA, CoQ, and intra-ovarian stem cell injections or exosomes, we usually give for 3 cycles and then start. But
Yes.
still, IUI is, I still feel that it's not a good option.
Yes,
One.
see, ma'am, should I share my
I
experience?
know, I know your explanation, and you have got the pregnancy. That's a good experience. Do good.
No, see, what I do in my all poor responders. So all
Yeah.
cannot conceive with IUI. Many of them will require IVF. Many of them will require egg donation also.
Yeah, yeah.
But then we can always try 2, 3, 4 months in all patients. So I give them pre-treatment in form of DHEA. If age is more, ultra Q300, folic acid, methylcholine, vitamin D, and since last almost 1.5 years, I have started using GCSF for 2 doses. There was a Japanese paper in Amsterdam X-ray. That group has given this 1 shot of GCSF in the early luteal phase of previous 2 cycles. Before starting IVF simulation.
For IUI.
Before IVF, they did IVF and they got more number of good quality embryos. They got stored embryos. So they got freezing. And surprisingly, 2 out of 5 patients, they had failed IVF, but they conceived naturally after age 42. I have used in my practice, I have got 6, 7 very surprising pregnancies. This patient is one of them.
Yeah, congratulations.
So we can try in every patient. If she doesn't conceive, definitely counseling this for IVF, egg pulling, as well as if required, womb donation. So real message is try, but don't expect pregnancy in every case. It cannot be possible.
Then regarding number of follicles, I think we should aim at 2 to 3 follicles.
Yes,
even the four follicle is a indication to cancel the cycle. That's what I feel. Four.
Ma'am, I would say my experience. I have pregnancy at 6 follicle also, 7 follicle also. And none of my patient in my career has ended up in hyperstimulation.
Multiple pregnancy.
Yes, multiple. We have quadruplets 3, 4 times, triplet many times. So multiple pregnancy is a definite complication when we cross follicle number 4. But again, most of the twins have come in the RAC FSH group. 2 follicle twins. So
maybe in your experience, but for the audience, I think we should give a message that even the
2 to 3 is the best. 2 to 3 is the best. Highest pregnancy rate, safety wise, less multiple pregnancies. Yes, ma'am.
Okay. Then low dose HCG is a fantastic protocol that we told today. And actually, there is no role for a combination. We also give combination of letrozole and HMG. But none of the protocols say that combination should be avoided. Combination of oral and the either it's a gonadotropin or it is a oral ovulogens.
Yes, ma'am. I don't know
many
why.
Studies say.
Why they said, because actually not only me, my whole area, all my trainees, we have thousands of pregnancies. So we are practicing in India. We are addressing poor patients. Just 3 injections.
Just to cut down the cost. Yeah.
Yes, just to cut. And it is.
We also do that. We also
do wonderful pregnancy.
Okay, sir. So otherwise, it is really excellent presentation. Congratulations, sir.
Thank you, ma'am. Thank you.
Okay. Thank you, sir.
Thank you.
Sachin Dalal sir is also with us. Welcome, sir.
Thank you so much.
His introduction is over, I think, Dr. Sachin Dalal.
Yeah. Let us start. After this fabulous talk by Paresh Bhai, it is going to be very difficult to match up his level of expertise. I will try to put on a few points here and there. What my suggestion is, I will not talk too much. We will give more time for question and answers if it is okay with the organizers. Yeah?
Okay, sir.
Yeah, so I'll share my slides. Okay, is the screen seen?
Yes, sir.
Okay, so I don't know whether Paresh Bhai spoke about GnRH antagonist or not. Did he speak about antagonist?
No.
No, he did not.
Okay, fine. So I will start from GnRH antagonist. I'll just run through stimulation protocols, what our idea is, contraindications. One thing what I would recommend to the audience is compulsorily do a HSG and document the patency of the tubes before going for IUI. The reason being HSG hardly costs 3 to 4,000 rupees. IUI will cost 15 to 20,000 rupees. So you have to have a documented spill before proceeding for IUI. And if the patient is not willing for HSG, you can always have the option of doing a sonosalpingography. And aim of ovulation induction should be for anovulatory women to ovulate. Ovulatory women, as you guys rightly said, to have 2 to 3 follicles and use of gonadotropins. That is all I am using. And that is all about, I'm going to tell about the stimulation part. I will straight start from the antagonist. So antagonist, where we will use the antagonist. What happens is that the follicles that we usually count is the 14, 15 millimeter follicles. And we don't really see the follicles which are the smaller follicles. Now, what happens is the smaller follicles are also contributing to the E2 levels, and this can also give a LH surge. So when you have used gonadotropins and when you are having a condition where there are 3, 4, 5 follicles, so in such a case, to prevent an LH surge, what we usually do is use half dose of cetrorelix. So use lyophilized. Lyophilized means the powdered cetrorelix which is available with a 2 ml diluent. Give 1 ml today, give 1 ml tomorrow. That is 0.125 today, 0.125 tomorrow. This will ensure that the LH surge does not occur and probably the pregnancy rates would be better. Looking at literature, there were 2 papers. One paper said it helps. Other paper said it does not help. But I would recommend to the audience that when you have multiple follicles, especially when you're using gonadotropins, you can think and the cost is not much. Now, did Paresh Bhai speak about the length of stimulation?
No.
Okay, fine. So now these are the tips and tricks as to how we can optimize the pregnancy rates. So this was a beautiful paper where they divided the patients into short cycle and long cycle. Less than 8 days was short cycle, more than 8 days was the long cycle. And they found that cycles with a longer follicular phase length resulted in a higher clinical pregnancy rates. And also the ET also increased with each additional day. So what this means to say is you should ideally aim to have minimum 9 to 10 days of stimulation. Now, there can be a problem of this when you are starting the stimulation on day 2. When you start the stimulation on day 2, the follicular phase length, you will see that it can get shortened. Instead of that, always start stimulation on day 3 and you will find that your follicular phase remains normal. Your follicle will begin to mature at 10, 11, 12th day. Nice endometrium will develop. Your problem of thin endometrium will not be there and you will have a better pregnancy rate. There was another beautiful paper where they evaluated the association of endometrial thickness and IUI results. In this, what they found is in 1,000 patients, they divided women into groups of 4, less than 7 millimeter, 7 to 10.4, 10.5 to 13.9, and more than 14. And they found that the best clinical pregnancy rates was when the endometrium was between 10 to 5 to 13.9. So what I usually tell the people in the group is when you have started the stimulation on day 2 or day 3, and on day 8, day 9, you have a follicle which is already 18 and 19 millimeters, and your endometrium is say 5 or 6 millimeters. This is the time when you should ideally look at the perivascular flow. Just a moment, I will like to show. Yeah, so this is the time when around the follicle you should see the perifollicular flow. See the PSV, if the PSV is more than 10 or not.
Slides
More
are not
often
seen.
than, yeah, I've stopped the screen share. I wanted to
Okay,
just show
okay.
it to them. Yeah.
Yes.
So see for the perifollicular flow, check for the PSV. If the PSV is less than 10, your follicle is 18 or 19, endometrium is 5 millimeters, wait for 1 day, don't give estrogen. Let the follicle grow, intrinsic E2 will come, and that is what will give you a better endometrium. Wait for 2 days, your 18 millimeters will become 20 millimeters, and that is when you will see a nice vascularity. and automatically your endometrium will jump to 7.58 millimeter. If that is in your PSV is fine, you can trigger give the trigger and then plan for the IUI. Or if you're doing even planned relations, you can do the same thing, right? So that is one thing that I tell again and again. And this was another Indian study where they compared the ET and IUI. Again, they also found that thicker the ET, that is 9 to 11 millimeters, that is when the IUI success rate was the highest. Now, stimulation part has been taken care of. I will talk about the lab setup for IUI. Now, it is very important that we do IUI in a IUI lab and not a pathology lab. A lot of times, colleagues, they do the semen sample processing in the pathology lab where there are a lot of VOCs, and trust me, it is going to affect your IUI results. You don't want your semen to be prepared in the same place where urine and stool examination is happening, and all sorts of chemicals are used in the pathology lab. So, what is an ideal lab? Okay, so just a moment, huh? Just a moment. Hello, how Viju? Yeah, so again, if you look at the laminar flow, if it is there, excellent. If it's not there, you have a clean room, that is also okay. What is mandatory is a Meckler's counting chamber that really will help you to improve your sperm counting methodology. Of course, a phase contrast microscope, a good Remy centrifuge machine. Now you're having a good newer machines which maintain temperature at 37 degrees Celsius. So if you are in a place like Bangalore, where the temperatures can go to 20, 22, you might want to invest in this. In places like Mumbai and Gujarat, where we are almost 34, 35, 37 round the year, then I don't think so that is much needed. And a CO2 incubator with a gas cylinder is desirable. Of course, disposables and trained personnel for IUI, and ideally an embryologist to do the semen sample processing. Don't take IUI lightly, because if you do your own data analysis, you'll be surprised, and I will be talking about that as well in the next few slides. Semen washing. Why do you want to do a semen washing? Why you don't just push the semen inside? I mean, someone can just tell that in natural intercourse, you are just pushing the semen in the vagina. Why do you want to spend money and do semen washing? The reason why you want to do that, it is completely eliminates the seminal plasma, dead sperms, WBCs, RBCs, and prostaglandins. And if you are going to push a raw, unprepared semen into the uterine cavity, that is what might cause uterine contractions. You don't want that. Another thing is there is a chemical activation of the ectosome membrane. Sperm motility increases. And since at around the time of ovulation, we are depositing the sperms into the uterine cavity, it minimizes wastage. And more importantly, you can do a pre-wash or a post-wash comparison. Another thing is, after the semen sample is ready, incubate it for 15 minutes minimum, ideally is 30 to 45 minutes before doing an IUI. Secondly, always look at the total motile sperm count. A total motile sperm count more than 5 million is what is ideal for having a good pregnancy rate with IUI. Now, there are three methods of doing a sperm wash. One is the conventional sperm wash, no longer recommended. I'm not going to talk about it. The slide mentions everything because it's a very old method and hardly anybody does it. Second method, which still a few centers across the country are doing it, is called as the swim up technique. Here, basically, what happens is there is migration of the motile sperm into the medium. This is for normal semen samples. And a high number of sperms with progressive motility are selected, and bacteria and cellular debris is filtered. What I would recommend, and what a lot of centers like us and a lot of colleagues are doing across the country, is basically a density gradient technique. What is it is actually recommended for? For samples where there is severe oligospermia, teratozospermia, asthenospermia. The method is that in a conical tube, the gradients are layered. Usually you have two layers, 40% and 80%, or 45 and 90. 1 to 2 ml of neat liquefied semen is layered. It is centrifuged for 15 minutes at 1200 RPM. Pellet is visualized at the bottom of the tube. Pellet is aspirated without disturbing the gradient and mixed with 1 ml of fresh sperm media. Again, this is centrifuged and supernatant is discarded and swim up technique is done. Supernatant is aspirated, mixed with media and incubated for half an hour. So this is how it is. There are two mediums, 40 and 80%. Sperm is layered above. Post centrifugation, you will have motile sperms at the below, and these are aspirated and swim up is done. And this is what is going to give you a very good pregnancy rates, a very good percentage of pregnancies with IUI. Now, again, if you look at the data, Cochrane says you do either of the methods, all three are equivalent. But in our clinical practice, we've actually found that with density gradient, the pregnancy rates are better. So best thing to do is you analyze your own data, which semen sample method is giving you good pregnancy rates, and go ahead with that. We do a gradient method for all. Another thing which is now available is the microfluidic chip. It's a beautiful thing. It is ideally used when the sample volume is ideally 1 ml and more, and for samples where there is high DFI. So what is usually done is the sample is layered from the inlet, and there are channels through which the motile semen are collected, and these are really good semen. And since there is no centrifugation that is done, the DFI is better. And there was a nice study which was published where they found that TMSC was lower in the microfluidic at baseline, and motility was higher at in the microfluidic. Pregnancy rates were 18% in the microfluidic group versus 15 in the density group. Look at the pregnancy rates. Pregnancy rates were 15% and 9%, and they found that microfluidic sperm sorting method significantly increased the ongoing pregnancy rates compared with the density gradient group. So what we do is, if the semen is absolutely normal, we go ahead with the density gradient group, a density gradient method. But in case there is, semen with a high DFI, or the patient has failed previous IUI cycles, then in such cases, we are now using the microfluidic chip for the semen sample preparation. Now, a few points to consider is the semen sample should ideally be prepared by an embryologist, or if not an embryologist, a trained technician in an IUI or andrology lab and not a pathology lab. Use Maker's chamber, incubation. IUI should be done within 1 hour of sperm washing. Again, long distance traveling of the sample should be avoided, and IUI should be done by personnel with due precautions. The timing of IUI after giving the trigger. So there are, two types of IUI that can be done. One, if the semen count is on the lower side, you can do a double IUI. In such cases, what we do is give a trigger and do 2 times IUI at 24 hours and at 30, and at 48 hours. And if the semen count is good, then what we do is do a single IUI after trigger around 36 to 40 hours. And IUI sample, this was a nice paper which they randomized into 2 groups, a 0.2 ml control group and 0.5 ml study group. And they found that the miscarriage rates were lower in the 0.5 ml group. This could probably be related to the presence of uterine contractions similar to those generated during intercourse, which may be implicated in the inception of early biochemical embryo endometrium communication. So what we conclude from this is, whenever you are doing a processed semen, ensure that there is minimum 0.4 to 0.5 ml of semen sample with which you are going to do the IUI. Now, a few points about doing IUI. Ensure that the bladder is partially full. The reason is, when the bladder is empty, there is going to be either an acute entry version or a retroversion, and the catheter will, go and hit at the internal os. Now, when you make the bladder partially full, it presses on the level of the internal os and it straightens the axis. So the catheter goes in very easily. Let the patient be in a comfortable dorsal position. Lithotomy is not really needed. If you do prefer, then it's okay. Cervix should be visualized with a speculum. We usually use a Cusco speculum. We don't use a Sim speculum, obviously, because the valsculum can cause some pain. Mucus is wiped till os is seen clearly. IUI catheter, we use the soft catheter, is navigated just beyond the internal os. You need to take the care to ensure that the fundus is not touched, because that can cause uterine contractions. You can fill the giveaway just beyond after the internal os. Another thing what I can suggest to people who are new to IUI is use a sonograph. sonography. So if the patient's bladder is full, keep a sonography probe, just the way we do an embryo transfer. You can see the catheter going just beyond the internal os and push it. Ensure that you push the semen sample for minimum 30 seconds to 1 minute. Push it slowly. And after the sample is pushed in, ensure that the patient is made to lie for 10 to 15 minutes, because there was again a paper which showed that with immobilization of 10 to 15 minutes, the pregnancy rates are better. Regarding soft catheter or rigid catheter, again, there was a Cochrane study which showed that there was no outcome difference. However, the pain was lesser with the soft catheter. So I think we all are using the soft catheter. Again, single versus double IUI. Cochrane, a beautiful Cochrane study, what they found is if the chance of pregnancy following a single IUI is 14%, chance after double would be between 16 to 23%. If the chance of live birth following a single IUI is 16%, chance of live birth following double IUI would be 12 to 27%. And miscarriage rates were almost the same in both the groups. IUM tips and tricks, we already mentioned a lot of them. If you are unable to navigate the internal loss with whatever method that we have mentioned, do a intracervical insemination. Here, you will keep the catheter at the level of the internal loss and push the semen sample very slowly. Some amount of semen will definitely go into the uterine cavity. Give a steep head low and keep the speculum there only. Don't remove the speculum, because there will be some processed semen which will be there in the speculum, which comes into contact with the external os, and that will also go back inside. Also tell the couple to be intimate on the day of IUI and the next day as well, because you want more semen going there. That increases the chances of pregnancy. If you're not able to, navigate the internal os, always advisable to do a hysteroscopy DNC and dilatation with lineation of the cavity to delineate, what is the length of the cavity, what is the angulation of the cavity, so that it will facilitate IUI or IVF if you are planning FET the next time. Misoprostol for cervical priming should strictly be avoided, because misoprostol along with dilatation will cause fundocervical contraction, and these are the contractions that you don't want. Now, a lot of times it is asked whether the IUI should be done in spite of, the follicle is ruptured or not. So in my center, what we do is we do a dual trigger. That is, we give a HCG 10,000 or a recombinant HCG with a Lupride 1 ml for all our patients, because we've had a few incidences of follicle rupture not happening, especially when only an HCG trigger was given. And after giving the dual trigger, that incidence has reduced to less than 2%. And you would actually prefer to do an IUI before the follicle rupture, so that the process semen is already there when the follicle is releasing the egg. Couple should be given a realistic success of IUI of around 15 to 20%. 4 cycle ceiling to be strictly maintained. Only exception that I do is donor IUI for azoospermia, where we go up to 6 tries. And this is one chart that you can always keep in front of you and explain to the patient. This is the age group less than 25, which has the highest pregnancy rates. But in this also, if you see after 3 cycles, there is a plateau. In the age group of 25 to 29, again 3 cycles. In 30 to 34, 3 to 4 cycles. And elderly, more than that, that is when you can go up to 4 or 5 cycles. But at our center, if it's a young patient, then 3 to 4 cycle is what is the maximum tries at IUI that should ideally be done. And if you have a patient who's 40-year-old, then give her a realistic success rate of not more than 5 to 10% success rate with IUI. Thank you so much. This is all that I had to share about IUI tips and tricks.
Thank you, Dr. Sachin Dalal. It was an excellent presentation covering all the points, how to increase the IUI results. There are some comments and some questions are also in the chat box. And number one, in case of...
Madam, just a moment. Before that, no, I would just like to share one document. Just a moment. Just give me one moment.
Yeah, sure.
So, can you see this Excel sheet?
Yes, yes, sir.
Yeah, so this is our actual live data. I have hidden the patient's names. This is the first 2 boxes. This is the age of the patient. As you can see, we've been keeping the data since not long, only 6 months or so. There are around 67 entries which are there. And
Okay.
I would recommend everyone to keep such a data. Why? Because before keeping this data, we were not sure whether IUI actually gives pregnancies. Now, when we actually kept the data, we were surprised with our own results that if you can count 1, 2, 3, this pink, the orange ones were the ones which landed up with missed abortion. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14 out of 67. So that gives a pregnancy rate of 14 divided by 67 of
20.
almost
20%.
21%, which in my opinion is pretty good.
Very
And
good.
this you will only be able to, ascertain if you can keep your own data. Another thing is, we've also mentioned which was the cycle, first, second, third, fourth. So majority, if you can see, are in the first cycle who have conceived.
Yes.
One in the second cycle, one in the third cycle. Otherwise, majority have conceived in the first cycle. This is my data. Okay. Your data can probably be different. Another thing is what was the stimulation that was used. So one patient FSH. Now look at the number of patients who have gotten pregnant with gonadotropins versus with only clomiphene or with letrozole. So one HMG, one letrozole, HMG, 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 HMG. These two patients, interestingly, they were both for IVF. This lady who had been given for 4 days, she forgot to keep it in the cold chain, So we did not cancel and we converted it to IUI and she conceived. And this woman, she was for IVF, but there was an asynchronous cohort. So I canceled it and then did an IUI again. This woman conceived. So this is only letrozole. This is HMG. Again, HMG, HMG. See, this is where there were 4 follicles which are developed. So we use cetrolix half for 2 days. Again, HMG and only letrozole. So from this data, we could make out that our HMG pregnancy rates are better. Again, looking at trigger, what we've done is we've given almost our HCG with Lupride for all our patients. And we also kept a count, okay, which luteal phase support was given. So we've given dydrogesterone. We've mentioned the brand names. You can use any. So dydrogesterone, duphaston, this thing is natural micronized progesterone. And what was the ET on the day of endometrium and who did the IUI, whether it was done by my associate or done by me, whether IUI was easy or it was difficult, results and OBS outcome also mentioned here like this. So keeping such a data will really help improve your analysis of the patient's stimulation and plan for the IUI. Yes, madam.
Yes, you can make your own study. So majority of the patients, they were younger age group, and they were used gonadotropins. And I also agree with the antagonist protocol in getting the IUI success rate and all the lab conditions you said, sir. And then about the microfluidic chip, what will be the cost involved?
Around 4,500.
That is in addition to the IUI cost.
Yeah, so what we usually do is our semen washing charges are 3,500.
Okay.
So instead of that, when you're actually using microfluidics, see our entire IUI package. Yeah, my IUI package, if I'm doing with only tablets, letrozole, we give a package to the patient. We don't say that itna injections hoga to itna charge rahega. So if we are not using gonadotropins, it is 18,000.
Okay.
If we are using gonadotropins, it is 25,000.
Okay, sir.
So for 1,000 or 2,000, we don't charge the patient extra.
Okay.
If the patient
what's the package, sir?
25,000 when we are doing with gonadotropins.
Okay.
And this includes everything, your sonographies, your injections, your luteal phase support, IUI washing, everything.
Yeah.
So that package works out very well.
Good, sir. Acceptance is good, sir. Okay. Then regarding the double IUI, so you explained when to do. Then what about the cumulative pregnancy rate is definitely better. And it is better to have a chart so that we ourselves, out of our experience, we can modify our own protocols. Thank you
Perfect.
very much, sir. It was very elaborative and clear-cut and crisp message that you gave to the audience.
Thank you so much.
Thank you, Sachin sir.
Thank
The
you,
one,
everyone.
wonderful, sir. Sir, the logging has crossed more than 100. That speaks for the quality of the talk.
Yeah,
And
yeah.
Thank you so much.
nowadays hardly 50, 60 will be the loggings.
Both the speakers, it was more than
Yes,
100.
the subject and the speakers both are excellent.
Thank you, sir.
Both of you. Thank
It,
you, sir.
it is
From the
it is efforts of the organizing committee of sharing about this.
Yes.
That is, I would say, see, we were only part of it, but more is the organizing committee. And Dr. Vidya has been very active in, promoting this conference, this CME and all the groups. And of course, faculty like Paresh Bhai always is going to draw more crowds.
See, when I'm talking with Sachin Bhai, then it's
Yeah, Actually, I have learned
new
from these
situation.
people a lot in our groups. So I want everybody to learn from those.
No, that's
Yes,
very good.
yes.
That's very good. That's very
Yeah.
good.
Thank you.
KSOGA
Thank you,
thanks
Dr.
both of you.
Vidya. Yes, yes.
Yeah.
But big
KSOGA
thanks
thanks
to
both of you.
Dr. Vidya.
Thanks for good
Absolutely.
organization and giving us a role to participate.
Yes. And thanks to allow us to speak in your society, ma'am. Thank you
Yes,
very much.
absolutely. That's more important.
Thank you. Thank you.
Bye. See you.
Okay, bye-bye. Bye.
Shilpa, you want to end?
Yeah, that was a good, wonderful session from both the speakers. Dr. Vidya, would you like to conclude the session?
Yeah. It was very good, informative session by both the speaker, beyond my expectations. And I learned a lot from these two people. So many teachers I have, but these are how they spoke about their experience, not of the books and everything. Whatever they do, they will present. Sir has shown his data. No one in this IVF era will show their own data. Never. Sir will show their charts in the groups. Whatever you want to learn, you can learn from those charts. Both the sirs. Thank you, Durgadas sir. Thank you, madam. Vanita madam.
Welcome. Yeah,
Bye.
welcome. It was a good thing.
Thank you, madam. Bye. See
Thank
you.
you, everyone. Thank you,
Bye,
sir.
madam. Bye.